Good morning and welcome to today's webinar, Medication for Opioid Use Disorder. Today's training is being offered by the Behavioral Health Quality Department and Behavioral Health Medical Directors and will be led by psychiatrist Dr. Brooke Parrish and licensed professional counselor Brooke Rowney Perez. If you have questions for the presenters, there will be time at the end for questions. Please type your questions in the Q&A box. All right, Brooke, we'll turn it over to you. Brooke, if you just come and take you right off mute.
Thank you. Hi, good morning, everyone. Nice to be joining you this morning. We'll go ahead and get started. We can hit our next slide. This is just our disclosures. We can hit next slide. Some learning objectives today. So we're just going to talk about general overview of opioid use disorder and talk about medicines used for opioid disorder replacement treatment, and then talk about some different interventions and treatment options and referral considerations and just common approaches to care. So we will go ahead and dive right in. So I'm going to talk a little bit about just an overview of opioid use disorder and some statistics. All right, so the DSM basically describes opioid use disorder as a problematic pattern of opioid use leading to problems or distress. And then in order to qualify as opioid use disorder, they need to have at least two of the following symptoms occurring within a 12-month period. So there's a list there of 12 different items. I'm not going to read through each one, but just a few of those that may be those things that qualify. Whenever a patient you are seeing maybe taking larger amounts of the opioid than intended or taking them over a longer period of time. If you have a patient who's having a lot of craving, strong desire, urges to use opioids, when you start seeing patients using them and they're having effects on their work or school or their home life because of the use of the opioids, maybe they started having some physical issues or some other mental health or psychological problems, and they continue using the opioid use despite all of these issues that are being caused. Or if they're experiencing withdrawal, or they're using to avoid having those withdrawal symptoms. Those are all different symptoms, all different items that, again, if you see at least two of those within that 12-month period, it could mean that your patient is meeting the criteria for that opioid use disorder. You can hit our next slide. Some of the biggest risks of opioid use disorder, some pretty serious stuff. Respiratory distress, I think, is the most, well-known and one of the biggest ones that leads to many other things. Could also lead to overdose, which of course could lead to brain damage or even death. Another way that opioid use disorder can really impact patients negatively is different cardiovascular changes. Opioid use can impact patients kind of in the short term with things like hypotension, bradycardia, but even can have a lot more long-term severe effects like heart attack or other heart failure. And then for patients that may use opioids through injection, that can lead to different serious heart infections like endocarditis. So just a lot of different ways that using opioids can impact the heart. Impairment to overall immune system. Again, there's various ways that opioids can damage a patient's immune system, directly, indirectly, but overall, just it can lead to some immunosuppression and can shut down that immune system and really leave patients open to infection, which can be a scary thing as well. And then we also have, of course, it leaves patients more susceptible to contracting possibly HIV, hepatitis C. There's hypogonadism, where patients have low levels of testosterone. And then another really important topic, and one that we will discuss throughout the presentation, opioid use disorder can lead to a lot of complications for women who are pregnant and their children. And so this is something that, again, that we'll talk about as we move through the presentation. Okay. Just touching on a couple statistics around opioid use disorder. What we're looking at here is the number of deaths from opioid use disorder in the United States. It's about a 10-year period. It covers January 2015 through January 2024. If you look on the right-hand side, there's a legend that shows you what each color line represents, which drug class, and you'll see that the black line on the top is opioids. And we can see a couple things. You'll see that there's kind of a steady trend from January 2015, started, moving up of the increase in opioid deaths. Then you'll see once we got to 2020, it had kind of stabilized out a little under 60,000. But once we hit 2020, there was a huge jump. And by the time we were up into 2023, it was over 80,000 deaths. And I think that, everyone knows that during 2020, we had huge increases in all substance use and substance use related issues. Opioids fell right along with that. But we just a huge, huge increase. I think one positive thing to note is you see in January 2024, we start to decline a little bit and start to taper off. So that is good that we are starting to see that trend go downwards, but still sitting above that 60,000 mark. So still many, many deaths that are being experienced using opioids. Still a very, very important topic. Next slide. And then I mentioned that we'll touch on opioid use disorder, talk about that and pregnancy. The prevalence of women who are coming in for delivery and have an opioid use disorder, it's getting higher and higher. This can lead to many different serious health outcomes for the mom and her child. Of course, it could be preterm birth, stillbirth, neonatal abstinence syndrome for children, which is when the newborns are born with the withdrawal syndrome. It can lead to even maternal mortality. So it can be a really, really dangerous thing for mom and child. And then just a couple of statistics around that. You'll see there on the bullets, there was an increase from 2010 to 2017 of 131% of documented women with opioid-related diagnoses at delivery. That's a huge, huge jump. And then from some data acquired from 2020, they're showing that about one baby is diagnosed every 24 minutes in the United States with neonatal abstinence syndrome, which is huge. That's a lot of babies that are being diagnosed and being born and dealing with that. So again, a really important topic. Dr. Parrish will talk more about this and more about how you can treat with medication-assisted treatment as we move through the presentation. So more to come on this. And I think on that, it is time. I will turn it over to Dr. Parrish.
Good morning. Thank you for joining us for this presentation. Anyway, next slide. As we all know, for opiates, they work by binding to various receptors in the brain, mainly mu, kappa, and delta. Now, the brain is not the only place that these receptors are present. For example, mu has all through the peripheral nervous system as well, and the GI tract, which causes, well, that wonderful side effect of opiates we all know as constipation. Also provides in terms of other medications that can help relieve that constipation. Delta receptors, again, responsible for mood, so that pain perception and reward, and again, that reward very much also plays with that euphoria of the mu in terms of addiction. Can also be found in the immune system along with the kappa receptors, and that is sort of helping tone down the immune system, which can help with inflammation, but it also helps in terms of getting that immune system down, which can cause folks to be more vulnerable to infection. Delta is also found in the GI tract, also in the heart. And in terms of kappa, you see it in the lungs and spleen. And your guess is as good as mine of what it's doing in the lung and spleen. Researchers are still looking at why it's there. Also seen in the heart as well. Again, not only are they distributed throughout the body, they are distributed throughout the brain and peripheral nervous system. Next slide, please. So treatments for opiate use disorder. We are luckily living in an age that we have multiple different treatments. By far and away, research has shown medication for opiate use is the most effective, bar none. However, we can reinforce those effects using behavioral therapy, psychotherapy, and certainly that combination of both medications and behavioral therapy can have quite a good impact. Given what research has shown, and again, we have also shown with research that the behavioral therapy and the cognitive behavioral therapy do not have to happen in order for medications to be effective. They can be effective in and of themselves. And that is one of those things that we really should note, that you should not require behavioral therapy in order for somebody to get medication for opiate use disorder. Furthermore, medication should be considered long-term. Next slide, please. So what are the benefits for medication of opiate use disorder? It certainly reduces the risk in terms of return to drug use. It really does help people live normal lives. They're able to work. They are not constantly seeking what is going to be their next, how they're going to get so that their next drug, so they avoid withdrawal. It can eliminate those withdrawal symptoms. It eliminates those cravings. And it really helps retain people in treatment, that so they can get treatment for perhaps some of the causes that cause them to go into the opiate use in the first place. And of course, for those that are injecting drugs, helps reduce the risk of contracting HIV or hepatitis C, and it reduces overdose deaths. It really does help save lives. Next slide. So what are medications used for OUD? We have several different medications. One is methadone, which is an agonist, buprenorphine, which is a partial agonist, however binds a lot more than most opiates. And then we have naltrexone, which is an antagonist. There are also several different investigational drugs that we're not going to discuss here. However, there is a bunch in the pipeline, and a bunch that are being studied. And I will just mention one completely investigational are the GLP-1s. So while I would not at this point prescribe such for only an opiate use disorder, if you're prescribing it otherwise, it may be worth knowing that. Next slide. So morphine milligram equivalents. This is sort of how we compare the different strengths of the different opiates. Each of them have different strengths. Morphine was sort of used as the gold standard. And this is one of the things that we can standardize sort of opiate doses across if we're prescribing them for pain. One thing to note is that you do have somebody that is on a chronic opiate and then you switch them, you can decrease the other opiate by about 10%. As they do not 100% align with the different opiate milligram equivalents in terms of the tolerance. And so you can go ahead and decrease that. Also, if you look at most of the drug monitoring databases, they will give a MME for that person. A lot of times, unless there is a very clear indication, you're certainly looking for an MME under about 90. Next slide, please. Here's some common MME conversions. One thing you will note that methadone actually has a not applicable. There is sort of conversion factor that of 4 for oral, 3 for IV. One that is very controversial is Suboxone. And the controversial in terms of many researchers believe that the MME is about 30. because it binds so tightly. However, buprenorphine actually has a sealing effect. Once you have binded, every single receptor basically has a sealing that you can't go any higher. And so again, the use of an MME for buprenorphine is quite controversial. Next slide, please. So methadone. Methadone was one of the original in terms of medications for opiate use disorder. It is a very long-acting opiate agonist. So it binds to the mu, kappa, and delta receptors, just the same as opiates. And it really reduces the cravings and withdrawals. Furthermore, it sort of blunts any effect of any other opiates that person may use, because those receptors are already bind with a more powerful drug. It is taken daily and it is available in a liquid, powder, or discus form. And for opiate use disorder, it can really only be dispensed through substance abuse and mental health services administered certified opiate treatment programs. That being said, methadone can be prescribed for pain. If you use it for pain, it is in lower but more frequent doses. And at that point, any prescriber can prescribe it for pain, not opiate use disorder though. Also, if you have somebody that is hospitalized, you can get methadone for a very limited period of time. Next slide, please. Things that a patient should know. One, never use more than prescribed. You should never share those medications. You should not take extra doses because you feel it may not be working. That's one of the things you tell the patient. Please go talk to your prescriber. Methadone also increases the QTC interval. While we know most opiates do not, methadone, much more than buprenorphine, methadone and buprenorphine can increase the QTC intervals a little bit. Again, we're looking at the kappa and delta there. And methadone much more. So if you're prescribing other medications, in particular, one thing would be antibiotics, looking at you, that ubiquitous Z-Pak, that may be something that needs to be taken with caution. When they first get started or dose increases, again, be careful with driving, operating machinery. Once it becomes a chronic medication, this is really not a concern. They know how it is affects, and it is really not a concern. But if they're starting or increasing doses, that is one of those things. Call 911 if overdoses suspected. Narcan does work. Store out of reach of kids and other folks that may be interested in taking the methadone. Store at room temperature. This is not something you want to leave out your southern exposed window, because that will degrade it. And obviously dispose of unused methadone safely. You really don't want to share it. Next. So common side effects, some people do get a little bit restless. Some people do have some nausea or vomiting. Remember the GI of the mu receptors in overdose can slow breathing, heavy sweating, again, constipation, that mu receptor. Interesting. And again, can cause some hypogonadism. Let's see, I think I lost a screen. Yes, maybe I can share mine.
Let me just 1 second. We're just having some technical issues and I will pull it back up. We're on the buprenorphine.
Okay.
All right.
I think we're on methadone still. Or
all right, let me pull that up for you. All right. Can you see? Oh, that's not it. Sorry about that.
It looked like it reproduced itself a lot.
We will try to pull that back up here. Can you see that?
Not yet.
Not yet. All right. Sorry, everyone, for that. I'm going to stop sharing one moment. Let me try this again.
Worst case, I can pull, I believe I have the presentation, I can pull it.
All right. Let's try it on your end, Dr. Parrish. Let's see.
All righty. Let's see.
All right. And let me pull it up on the screen. Oh, there we go. I
You
think
got it? All
yeah, we
right.
are
Super.
back.
You got
Sorry
it
about
before I
that.
did. So definitely, obviously, in overdose, difficulty breathing, feeling lightheaded or faint. Again, methadone does have that prolonged QTC risk. So you do have the potential of, if combined with other medications, going into torsade de pointe, and having that fast pounding heartbeat that would be considered serious because if you're in torsades, that obviously would be considered a code. Some people, there are case reports of hallucinations or confusion or it causing a delirium. Next slide. Buprenorphine. This is a older medication, but is newer than methadone at this point. It is a synthetic opiate that binds really, really tightly. Remember, the sort of controversial number out there is a 30 for MME. It has a low to moderate potential in terms of physical dependence. Um, Many people would argue that yes, it can cause very much a physical dependence that you do have to taper off. It certainly can also be used to treat pain, and it is also used as a medication for opiate use disorder. Um, it is now considered called MOLD. It used to be MAT, medication assisted treatment, now medications for opiate use disorder. It enables people to work, um, live a normal life, as opposed to working to find where's their next craving, where is their next drug. The effects are much weaker than an opiate because remember, it's that partial agonist. So it's not a replacement for an opiate. It binds to those receptors, cutting those cravings without giving those euphorias and other effects that we see with opiate use disorder that leaves people not as functional. It really increases the safety in overdose because it does have that ceiling effect and it doesn't hit the respiratory depression nearly as much, and it really does not have the potential for misuse the way an opiate does. That being said, it does have street value, and a lot of times it has street value for people looking to do their own versions of medication for opiate use disorder. Next slide. Other things to know about buprenorphine, that if you give buprenorphine without the person being in significant withdrawal, looking at a CALS around that 8 or 9, you can cause a precipitated withdrawal. And which, besides being extremely unpleasant, there have been occasional cases of what is called Takasumi's or the broken heart syndrome. Typically, we see that, of course, with extreme emotional distress. That is probably some of the worst that I have seen in terms of precipitated withdrawal, and those are some worst case scenarios in terms of worst case reports. Again, not something to be terribly afraid of, but again, you really want that person to have abstained from opiates for a significant piece of time and really looking to make sure that they are within that sort of CALS of 8 or 9 before starting the buprenorphine. The length of time for which a person can be on buprenorphine really does need to be individualized. And again, this is one of those things that I always worry about somebody that is going to say, will take this and then I want off of it within a week or two. The best results research has shown is really for those people that are on this medication for an extended period of time, at least months, if not years, and in some cases really does need to be indefinite. One of the things I do hear is, well, aren't you just substituting another drug? Well, yes. However, the way I look at it is just like that diabetic that needs to be on medications for the rest of their life, be it a metformin, be it insulin, or whatever, that diabetic is going to be dependent on medications, just the same as somebody that has opiate use disorder will need to most likely be on medications or really have gone through some of that behavioral change, and it will still need to be a long-term medication. Next slide, please. Other things, patients should not take their medication or not take other medications without consulting their doctor. Again, this does have that sort of prolonged QT, so they should definitely let other providers know. Again, those medications such as azithromycin that we know prolong the QT interval. While not as much of a concern as with methadone, certainly they do need to let other prescribers know. They really should not drink alcohol or take other medications. Certainly they should not take opiates on it, sedatives, tranquilizers, or any other medications that repress that respiratory drive. Again, it is much safer than any of the opiates. However, it can have some effect with respiratory drive. The physician should monitor any liver-related issues. Again, this is pretty minor concern, but buprenorphine and methadone are processed through the liver. And one of the things I would like to add, if you have an elderly patient, for buprenorphine, you actually do not adjust for an elderly patient. Certainly for opiates, including methadone, you will adjust for elderly patients because they do not metabolize opiates. So you're either going to lower the dose and extend that time between doses. For buprenorphine, you really do not have to. Buprenorphine, unless it's being given for pain, is once a day. And again, you will tend to not adjust for an elderly patient. Certainly, we're going to talk a little bit about pregnancy or those that plan to become pregnant. Both methadone is considered the gold standard. However, buprenorphine really has gotten that research behind it that now it is considered safe in pregnancy, and it is certainly considered less risk than using opiates. Again, needs to be stored out of reach from prying hands, especially little prying hands, and medication really should not be shared. Next slide, please. So side effects, again, can cause some constipation, does not cause constipation nearly as much as opiates. Some people have had headaches, but again, can also be used for headaches. Nausea and vomiting, much less seen than regular opiates. Dizziness, drowsiness, fatigue, sweating, dry mouth. Again, most of these are fairly minor. A lot of these, if you notice, can cause from precipitated withdrawal if precipitated withdrawal has been an issue. Some people do report some insomnia. Again, other people report that it is helpful for their insomnia. Tremors, palpitations. Again, the serious respiratory distress, again, much, much less than a regular opiate, can be an overdose. However, again, remember, buprenorphine has a ceiling effect. After hitting around 24 milligrams, taking more actually doesn't do anything more. Some people look at adrenal insufficiency, again, something that is very rarely seen. Withdrawal, there are withdrawal symptoms if you suddenly cease buprenorphine. Given that there is a long-acting buprenorphine that is injection, some people have had some pain at the injection site. Some people actually have gotten abscesses at the injection site that have required surgical. But again, a lot of times that will have to do with technique of injection for a depot medication. There is some neonatal abstinence syndrome that can be seen in newborns. However, one thing to remember is that buprenorphine is considered safer than insulin. Next slide, please. Naltrexone is the third medication we're going to discuss. It is not an opiate. It actually blocks the opiate receptors. It is not addictive. It basically blocks the euphoric effects on the mu receptors for the opiate. If you stop naltrexone, it comes both in a pill and an injection form. The pill must be taken daily, 50 milligrams. The injection is generally monthly. It can be administered and prescribed by any practitioner licensed to prescribe medicines. For buprenorphine, I should note that any MDDO can prescribe it. However, those that are advanced practice nurses or PAs will need to take a 25-hour, or is it 24-hour course before they are able to prescribe it. Naltrexone does not have any of those stipulations. Furthermore, naltrexone can also be used for alcohol use disorder. Next slide, please. Things to know about naltrexone is that it can be used for opiate use disorder. This is a medication that you really want the person to be fully complete with withdrawal, because this definitely can cause a precipitated withdrawal. If you are basically tossing everything off of the receptor and binding to it as an antagonist, those that have current liver problems, it is also metabolized through the liver. Sort of the break point is those that have greater than 3 times normal liver enzymes probably are not candidates for naltrexone. It does work with alcohol use disorder as well. However, does not appear to have much effect with other illegal drugs. It also can decrease platelet activation. Typically, this is not something that we really need to worry about with clinically, unless somebody also happens to be on medications for either stroke or MI, such as Plavix. That can be an issue. Also, again, if you have somebody that is in liver disease and already has a decreased platelet count because of their liver disease, that is also something to definitely take into account. Again, with kidney issues can be an issue, but much less than the liver issues. Certainly any other medical conditions, such as if they're being treated for stroke or heart attack, again, because they're probably already on those medications, that may interact. And if they're taking any opiate-containing meds, especially if they happen to be on a chronic med, that contains codeine or something along those lines. It can cause issues. The antidiarrheals also are basically a very weak opiate medication, and that can also cause issues. Next slide, please. So common side effects can be some nausea, sleepiness, headache. Interestingly enough, very low dose naltrexone has been used off label for chronic headache. So some people it causes, others not. Dizziness, vomiting, decreased appetite, painful joints, muscle cramps, cold symptoms. Again, looking at sort of that precipitated withdrawal if they were not off their opiate long enough. Severe side effects, again, if not injected with correct technique, can cause some issues at the injection site. Again, those that have liver damage or hepatitis already really do need to have some caution. Again, that 3 times liver enzymes or already a decreased platelets. Certainly if somebody already has cirrhosis, probably not the medication for them. If there's serious allergic reactions, again, pneumonia typically could be an aspiration pneumonia, again, from the vomiting, or some patients actually may have some depressed mood, but again, this is quite rare. Next slide. Moving on to treatment of opiate use disorder during pregnancy. Next slide. During pregnancy, again, opiate use is incredibly serious. You have 2 patients, and certainly pregnant people are more at risk, again, for overdose. So treating opiate use disorder is much more serious and should take priority. And again, both methadone and buprenorphine have been shown to be safe and effective in pregnancy. Those that are born that have had been born to people with opiate use disorder, premature birth weight, premature birth, low birth weight, and again, also a withdrawal syndrome in the neonate, which really, in terms of bonding, creates a difficulty in bonding, both short and long term, difficulties with feeding, and this is known as the neonate opiate withdrawal symptom. Next slide, please. Again, opiate use during pregnancy, as we've sort of already mentioned, that medications for opiate use disorder are safe and effective for pregnant people, and certainly their safety is been documented much, much higher than the risk of a untreated opiate use disorder. It can help prevent withdrawal symptoms, and it reduces, again, the risk of returning to opiate use, both during the pregnancy and during the postpartum period. It can really help them get their care on track and stay on track. And breast milk really contains minimal amounts of methadone and buprenorphine, and is considered safe for the neonate. And furthermore, breastfeeding can lessen the risk of and severity of a neonate withdrawal opiate syndrome. So treatment should be offered as soon as possible, as soon as opiate use disorder is identified, and especially again in pregnant people. Methadone and buprenorphine are first-line treatments, along with behavioral health and medical services. Naltrexone may be used, but really we have so much less information as opposed to methadone. Methadone, we have a lot of information showing how safe it is. And buprenorphine, again, we have growing information, and it is at this point considered safe. And the risk benefit really leaning towards that benefit. Longer duration of MAUD could be considered, especially to go on into that postnatal period, so that they can continue to bond with their babies and have less of that risk of relapse. Next slide. And I believe I turn it over to you, Brooke. Thank you very much.
Thank you, Dr. Parrish. So we're going to close out the presentation talking about just some overall success strategies for treatment, some ideas when working with this population. Okay, one of the most important things when it comes to working with this population is that there's not a one-size-fits-all approach. Every patient that you work with when it comes to opioid use disorder should really have an individualized plan tailored to them. Even as Dr. Parrish was talking about the different medications that can be used to treat opioid use disorder, there's multiple kinds and everyone's going to need something different. So really, really important to focus on that. Discussing that long-term use of medication for opioid use disorder. As Dr. Parrish said, many studies have shown that long-term use of this medication treatment can result in positive outcomes for this population, which is great, and great that we have access to these things now. The next couple bullets talk a little bit about the importance of the terminology that you use. So using medical, neutral, and person-first terminology is really best with this population. A couple examples of that, maybe if you're referring to like a urine sample for a patient, never to use the terms dirty or clean sample, but instead to say a positive or negative sample. Another example is if you have maybe a patient who is not attending to their treatment plan, instead of using just non-compliant or unmotivated to describe them, using something like, maybe a patient disagrees with the treatment plan or they're not participating, things like that. Another really important one that's just always important, I think this is important to remember when you're talking not only to the patient, but when the patient's family as well, is to never use the term really addict or user, but instead say a person with an SUD or a person in recovery. And so that can really go a long way. Using that person first language and those neutral terms can really help you when working with this patient population. It helps focus on the individual. It helps instead of just their diagnosis. It helps take away some of that stigma and that shame. It helps, and when you do those things, it's going to help you in increasing that overall just treatment bond and being able to have that better relationship with your patient, which will lead to better outcomes. So all of that, really important when approaching this population. Another really, really important thing to always do with any patient you have who has been misusing opioids or has an actual opioid use disorder diagnosis, they and everyone in their household should receive overdose education and naloxone education, and they should receive a prescription. This way, when you have if someone else is in their household and something happens, they too have been educated and they know what to do in the event of this kind of emergency, and they'll know about the naloxone and how to use. So really, really important to always do this with patients. Multiple studies have shown this as well has prevented many overdose deaths. Super important. And then another thing is if you have a patient coming in, maybe you're a primary care physician, they're coming in with some other primary issue to see you, maybe high cholesterol, hypertension, or something of that nature, but they also have opioid use disorder or another mental health or substance use diagnosis. It's important to include that as a primary diagnosis in your documentation as well. That way, as a patient moves through different providers, They go on to see other treatment professionals. It's documented well in their records that they have this. And this is always going to be something of importance, even if they are in recovery. This is always going to be something that a fellow practitioner or someone treating them down the line is going to want to know. And so it just helps with that continuity of care. So that's something to note as well. Next slide. Another really important thing with this population, we talked about focusing on a really individualized plan. You want to develop a collaboration, a partnership with patients when it comes to designing their treatment plan and their goals and how you're going to treat this opioid use disorder. You want to focus on their concerns and their priorities. And that may be something as simple as you may think that they really do need some counseling or therapy, and maybe they do at some point, but maybe in the immediate moment, that's not their priority. Maybe their immediate priority is remaining on medication for this opioid use disorder, and their immediate priorities are getting stable with housing and with employment, and that's not on the front line for them. And so you meet them where they are and help them with those things and help them set goals, and maybe eventually again they can get to that, but that may not be their priority in the beginning, and so you really work with them and help them with that. Using the 5 A's at every visit is really important, and you see on here those 5 A's include assess, advise, agree, assist, and arrange. And basically what that means is that every visit you have with the member or with the patient, you talk with them and you check in about what's going on. You want to check in about substance use. You want to check for any relapse. You want to check for withdrawal symptoms. You want to check for side effects if they're doing medication. You want to check what's going on otherwise physically. Are they having any other physical health concerns? Are they having any other mental health, psychological issues that need to be addressed? You want to check with them what's going on at home, what's going on work, school, all of those things. And within that, you'll learn of barriers. You'll learn if there's anything going on that's keeping them from maybe, say, picking up their medication for treatment. Are they having any transportation issues, financial issues? Is there any way you can assist with that? Do they need any kind of resources? Do they need any referrals? Can you help set that up? A big piece is making sure at the end of every visit that you have the next visit already scheduled, that you have that booked with the patient. If they do need a referral, they do need to get seen by someone else, you have those referrals provided. Maybe you have helped them get set up with additional providers. Just making sure that everything is set up and they have everything they need, and making sure that as you go through treatment, maybe you've been seeing this patient for 5 months and you think, oh, I don't necessarily need to ask some of these questions. I already know the answer. We've already addressed it, but things could have changed. Significant changes could have occurred. So really important to keep checking in with this population, with these patients as you continue to meet with them. And then another important thing is if you have maybe someone in your practice, or even if you don't, referring patients out to expert patients, which may be peer educators or like recovery support assistants, people that have the lived experience can really, really be a big help with this patient population. So if you have access to any of that you can help connect a patient with, or you can refer them out to someone, that can really, really be a big advantage for this population as well. And I touched on, all the different things. These all help ensure that continuity of care and that the patient will continue through. Next slide. And then the next couple of slides just talk a little bit about some harm reduction approaches and working with this population too. Some things that you can do, that you can focus on or provide referrals for. So one thing is, if you're working with this population, possibly drug disposal bags. These contain activated charcoal, and that's going to it's going to neutralize the opioid, and then they can safely dispose of those. And that studies have shown that patients are more likely, if they're given these drug disposal bags, to dispose if they have excess opioids at home. And so that's a great thing there. Another thing that can be helpful are locking caps with combination. This can kind of prevent a couple of things. If you have someone that they're having a rough day and they want to just impulsively go and grab for that bottle, and they're just like, I'm having such a hard time, I'm just going to take a pill. if they have that locking cap, that combination, it might slow them down enough that they stop and really think about it before they take a pill, before they get into that again. It might deter them and keep that from happening. Another thing is, of course, if you have other people in the household, especially children, will keep them out of that medication. So those are two things that can be really helpful. Next slide. And then other things, safe injection sites and clean needle programs. Different studies have shown that safe injection sites, they are associated overall with a lower overdose mortality. Syringe service programs can help users learn to properly administer that naloxone that we talked about to help prevent overdose as well. These can both be really, really helpful. One of the concerns with programs like this is that it's going to increase use or increase crime, use of illegal drugs, but out of a couple of programs they've been researching in Baltimore and New York, they found no increases in illegal drug use or crime with those programs, which is really positive and really positive to hear. And so another thing that could be helpful to keep in mind with this population. And next slide. All right. And so these are just provider resources. You'll see on the left, there are some national resources that you can access. And on the right, state-specific resources of any of these that you want to look into or anything you want to use to refer your patients to. And then the next slide is going to be, we can flip through that, sources that we've used throughout the presentation. You can definitely deeper dive into these and read some of these things if you want to learn more information. And then we can hit the next slide. The next two slides are videos. There are short little member videos that we created that you can share with patients. There's two slides that have multiple. There are ones that are addressing substance use. There's one about opioids specifically. There are also videos around mental health medications, post-discharge from an ER or an inpatient mental health admission, and how members can follow up. The videos just give them some information about these topics and also resources or who to reach out to if they need some assistance with any of these things. You could provide these if you're interested, put these in your waiting rooms possibly. If you have any paperwork in your waiting rooms to share with patients, add them to patients' discharge paperwork, and then the patient can just scan the QR codes and access those links. And so with that, I think this concludes the presentation.
Does.
So
Thank
I
you
think now
so
we'll
much.
take questions. Thank
Yeah.
you.
Before we get into the Q&A, I just wanted to make note that you'll receive an email link for the evaluation and attestation for this webinar today, 24 hours after the event ends today. And then there will be a copy of the slide deck at the same site that you can receive your CME and CEU. But Dr. Parrish and Brooke, thank you for a great presentation. I want to open it up right now for any questions. Right. Wow, you covered so much. If you could just go to I think this is the last slide, Mackenzie. There's one more. All right. Um, well, with that, again, you will receive a link via your email that you used to register 24 hours after the event today with that evaluation and attestation. If you can please complete both of those, and that will allow you to receive your CME or CEU credit. A copy of today's deck will be available at the same site that you registered for today's webinar, and a recording will be made available online. So you can always go back and access today's presentation. We just saw a new post, new question that came in. It just said, thank you very much for today's presentation. So great job, everyone, and thank you for your time this Monday.
Thank you.
Thank you.
Thank you.